My name's Dr. Susan Rucker. I'm a professor at Queen's University of Charlotte. Can you hear me? I have the distinctive honor of introducing Dr. Yele Aluko. Healthcare has changed very rapidly, and he has changed with it throughout his career. He's been a prominent cardiologist here in Charlotte. He's been the cardiologist for the Hornets. He's been the medical director and senior vice president at Novant, and in consulting, he's been with Ernst & Young. He's been medical director, and he's also started a TikTok blog to help with healthcare literacy. So very humble man, keeping it short, but he'll bring in a lot of information for you. Dr. Lupo?
Thank you. Thank you, Dr. Rucker, for your generous introduction. I want to say thank you to the NAACP and Health Justice for your vocal, for your visible, your tireless advocacy towards health justice and health equity for all. I want to thank Little Rock AME Zion Church for hosting this important conversation. I want to start by sharing with you what I've learned over more than 2 decades of practicing medicine at the bedside as a cardiologist right here in Mecklenburg County and adjacent counties. What I've learned leading large groups of physicians across multiple specialties in a Southeast regional health system of 14 hospitals across 4 states. What I've learned in Big Four management consulting, engaging with C-suite health leaders in the health industry, and also with a lens of what I have learned from health markets outside the United States, in the United Kingdom, the broader Europe area, in Asia, in the Middle East, and in Africa. And I'll tell you what I've learned about the American health industry. And it is this: we don't have a health industry, we have an illness industry. We have an industry that is very efficient in treating disease, effectively once diagnosed, and expensively once diagnosed. We have not developed a system that allows us to have insight into preventing disease. And that difference that has evolved in the American health industry context, the difference between treating illness and preserving health, has led to the country we have today versus the country that we were promised. And what do I mean by the country that we were promised? We go back to the 14th Amendment that speaks to equal protection under the law to any born American or naturalized, and further enshrined by the 13th Amendment and the 15th Amendment. We are living in a country that has not lived up to its promise to all people. This is not an accident in the health industry. This is how it was built. This is how it was designed. So tonight I want to elaborate a little bit and I ask you to walk with me so that you can understand the architecture of this build and understand how it has failed and understand why it has failed Black and brown people the most, but also come away with the understanding that it's actually failed all Americans. Most importantly, I want to share with you what we can do as a collective, not in Washington, D.C., not at the next election, but what we can do in our families and in our communities. There's a reckoning that we have to come to, and that is that The United States has never prioritized policies that drive good health for all Americans. I want that to sit with you. Has never prioritized policies that drive good health for all Americans. Dr. Sachs is somewhere here, and she will agree with me that that is what in medicine we call population health. Countries that commit to develop structure and process that guarantees that all citizens can get the best shot at good health is called population health. The United States of America, surprisingly, does not have this principle written in its health policy. Rather, American policy has prioritized individual care, which is predicated on individual health coverage. Do you have health insurance? We spoke about that already. Do you have health insurance that will pay for your doctor visits? Do you have access to physicians, depending on the insurance that you have? Can you afford medical care, even though you have insurance? That is the context of America's health policy. And while we understand that there are certain drivers that we call the social determinants of health, drivers that predispose one to illness, we don't have a policy that attenuates in a systematic manner all adverse social determinants of health. And this has resulted in what is very commonly known that the United States of America spends the most money per capita in the world, and the most amongst the wealthiest nations in the world on individual health care. And despite doing so, the health outcomes are in the bottom 20% of the best performing countries. This is not an accident. This is a design choice. There was mention just now about maternal mortality. And I'll tell you that the best practices in maternal mortality in the world, Ireland, 2023, out of 100,000 live births, 0 maternal mortality in Ireland. Less than 2 in Norway. United States, 2024, 18. Black women, 2024 in America, 45 out of 100,000. So the outcomes we have, we've known for decades. And I want you to understand that this is a predictable outcome of the architecture that the industry has given us. So I want to talk about the fact that this did not start in 1965 when Medicare was written into law and Medicaid. It has persisted through 2010. The Affordable Care Act, which you all know, provided significant value to American society. But I'll tell you that this architecture began at a time when America actually had its first chance to build something different, and it did not. It began in 1865. We have to go all the way back to the end of the American Civil War and during Reconstruction to understand why what we see today can be traced back in history. During Reconstruction, after slavery, Abraham Lincoln did not a very universally known, but a very laudable thing for African Americans by creating the Freedmen's Bureau. This was a time of promise, but also a time that ended up being one of abandonment. It was an unprecedented mandate to provide food, shelter, labor opportunities, educational opportunities, and healthcare. For 4 million Black Americans who were previously enslaved and suddenly became free men and women. The Freedmen's Bureau, at its peak, had 40 hospitals serving freed former Black slaves and poor, displaced white Americans displaced by the war. And then we had the 13th Amendment that abolished slavery. As I mentioned, the 14th Amendment, equal protection and civil rights, and then the Voting Rights Amendments. The Civil Rights Act in 1866 enshrined these protections as statutory. But fast forward today, we find that while the theoretical context was established then, centuries later, we have what we have. Now, the Freedmen's Bureau was not a vague aspiration. It was a real thing. There were explicit federal commitments. It lasted only 12 years because there was political pushback. And it got defunded in 1872, and Reconstruction was traded away in 1877. And it went down in history as a failed political experiment. This was the first time, but has not been the last time, when America's health policy chose financial convenience over moral commitment. Despite that, and since then, the architecture of America's health industry has continued not to support those who it should and should have protected the most. The 70 years after Reconstruction, many of you know this, was the Jim Crow era. When we talk about healthcare in America, there tends to be a tendency to skip over the aspect of these 70 years after Reconstruction during Jim Crow. But it's important for us to understand that during this time, the country began to build organized medicine, to build the modern practice of the times of medicine. Black Americans were excluded from these processes. Black Americans were excluded from medical schools, from nursing schools. The American Medical Association denied Black physicians entry. And then something significantly important happened in the history of American medicine. In 1910, the Flexner Report was released. The American Medical Association had commissioned Abraham Flexner, with the backing of US Congress, to do an evaluation of all medical schools in America, to see which ones were of poor quality, and to consolidate medical schools seeking to have a more organized pipeline of medical doctors coming out of training. That Flexner report reduced the numbers of medical schools from about 100 to about 60. There were 7 Black medical schools at the time. 5 closed. Only 2 were remaining. Howard University and Meharry survived. And for 50 years after that, any Black doctor that trained in the United States of America was trained at either Howard or Meharry. And this single act of the Flexner Report paralyzed, crippled medical training for Black and brown doctors for 3 generations. It created a jaundiced eye about Black doctors. Flexner said that Black doctors were inefficient and were not suitably trained to be doctors. He suggested that they should be assistants, and that they should not ever participate in medical research. That stigma and that taboo still exists today, and it started in 1910. The architecture I've described continued to be built with disregard of those that needed support the most. And then we come to World War II. During World War II, with the economic crises that accompanied that, and with lots of young American men fighting abroad, wages were frozen in the United States, and employers could not compete for labor because of frozen wages. So what employers did to compete in the market was they began to offer employer-sponsored insurance, ESI. So rather than paying additional money, people who were working got health insurance. The federal government then stated that employers that provided health insurance would not be taxed on that level of investment for their employers. This was a laudable thing to do, but what was the outcome of that? This is another strange moment in American history where by accident, America inadvertently tied health insurance to employment at a time when most Black and brown people were denied entry into organized employment. Agricultural workers, domestic workers, self-employed people that could not afford to purchase the only source of insurance at the time, which was employer-sponsored insurance. De facto, African Americans were excluded from participation in health insurance. Now, fast forward to 1965, when Lyndon Johnson signed into law Medicare and Medicaid, with significant resistance from the American Medical Association, the umbrella organization whose primary purpose and commitment was to advocate for healthcare access and healthcare delivery for all Americans. The AMA resisted, but Medicare and Medicaid in 1965 was signed into law. This was a patch on a Band-Aid that was festering, but it was a significant achievement. And with that was the desegregation of American hospitals. This was not a spontaneous moral act. The desegregation occurred because President Lyndon Johnson informed all American hospitals who refused to desegregate hospitals in 1965, when that amendment was signed into law. In 1966, he informed all American hospitals that they would not be recipients of federal funds if they did not desegregate. Within 45 days, all American hospitals desegregated because of the risk of financial impacts. Now, that was not rebuilding. It was another patch on a festering sore. With Medicare and with Medicaid, we had elderly patients now covered, Black and white. We had those under the poverty line now covered, Black and white. But it left several people, Black and white, who between the ages of 18 to 65 years of age did not qualify for Medicare, nor did they qualify for Medicaid. And if they were not employed, they did not have insurance. And disproportionately, this impacted Black and brown Americans. 2010, the Affordable Care Act. And this I will describe as the most sophisticated patch on a festering, boiling sore. It achieved significant value. It created marketplaces. It created Medicaid expansion across many states. It abolished denial of pre-existing conditions, tenets that were in place before the Affordable Care Act. At its inception, 10 southern states refused Medicaid expansion, these states with the largest Black populations in the United States. This was resisted systematically and systemically, most fiercely in the American states where it was needed the most. This was not coincidence. This has been the pattern. This architecture continued to be built without providing an opportunity for those who needed it the most. So, over time, health disparity gaps have narrowed, but as of now, there is a 5 to 7 year disparity gap in life expectancy between white Americans and black and brown Americans. This is not a failure of effort, it's a failure of design and accountability. We've built systems for healthcare coverage. We've built systems for treatment. We've built systems for billing, but we have not built systems to preserve health. And please hold on to that, because it's taken me a long time practicing medicine and understanding the macroeconomic systems in healthcare to realize that it is because we've never had a population health focus. We've never built a system designed to prioritize good health for all. So the question is not why black outcomes are worse. The question should be, why is anyone surprised? Why are we expecting them to be better given what we know has been built? So I want to tell you a personal story and how I learned that what I've just told you now is history, but it's not really history because it is present-day reality. I did my last cardiology fellowship at the University of Massachusetts Medical Center in Worcester, Massachusetts. So it's a fourth-year fellowship. I was the most senior fellow, and I was the only African-American fellow. We had a pyramidal structure. As most senior fellow, I had about 15 fellows reporting to me ultimately. The fellowship I was doing was called an interventional cardiology fellowship. And I was learning how to do what we call coronary angioplasties, where we use balloons to open blockages in people's hearts. At the time in the 1990s, that was cutting edge. I was in the first year of American Fellows to be trained formally in angioplasties. That was the time that the American College of Cardiology had mandated that any physician who wanted to practice interventional cardiology after training had to do 1 year of angioplasties. My year was the first year it happened. So here's where I'm going with this. After 6 months of being in my program, on a Tuesday afternoon, it occurred to me while I was in the cath lab that I had never done an angioplasty on a black patient. After 6 months of being an African-American interventional cardiology fellow, being exposed to 75% of the procedures being done, that I had not done one on a black patient. That stunned me. In a community where 1 in 9 people were black, and in a community where cardiovascular disease was the #1 killer of African Americans, I, as a black cardiologist, being trained in the most sophisticated process and technology, I hadn't seen a black patient that required my services. Now, it's not that there are no black patients with heart disease, nor is it that I was prevented from treating them. What occurred to me was that I was within an engine where pathways were broken. And these broken pathways were not visible from the inside. And then it began to occur to me that I was inside this machine, and this machine was not delivering care to people who looked like me, even though the care was available to them. And even though they had access to care, some of them had Medicaid, some of them had Medicare. And after I realized that, every piece of history I've mentioned to you today just walked you through Reconstruction, Jim Crow, Flexner, employer system. Every patch on that foundation that was never rebuilt after it should have been built. What I learned, I could not have learned from a textbook, from any medical journal. I learned that day on who was not on my list of patients to treat in the cath lab. American health industry history was alive when I was a fellow. It was there in my hospital on that day. And that moment has never left me. So what did I do about that? I came to Charlotte to practice here, but I began to delve into research about issues of access to healthcare. And how could it be that if you had Medicare or Medicaid, and if you're African American, that you may not get the right level of care? And with other healthcare leaders, Dr. Sachs will remember this, we built the Carolinas Association for Community Health Equity here in Charlotte, North Carolina. We had 5-year symposia seeking to drive awareness to community leaders and to healthcare consumers. After 5 years, we didn't have codified data that showed that anything was changing. So information was being disseminated, but outcomes were not changing. Therefore, the Bank of Americas, the Wachovias, and all the other funders stopped funding us. Inside my practice, I did some things with some of my colleagues that are harder than it sounds. I made sure that we began to hire cardiologists that reflected the patients that we were failing to reach, patients that looked like us. This work is not done. And as I said, my fellowship taught me things that I could not find in a medical textbook or experience from a medical journal that I will never forget. The system we're in is not broken. It's producing exactly what it is designed to produce. And it was never designed for population health. I want to tell you something else that took me years of research and practice to fully understand. When I understood it, it changed the way I think about medicine at large. It is true that health outcomes, adverse health outcome rates are higher among blacks than they are among whites. But what is not well known, this is where the narrative around health disparities has been hijacked, is that there are more health disparities in white Americans than there are in black Americans. But the narrative has racialized this. Why do I say that? That is because numerically, there's so many more white Americans than black Americans in America. Therefore, numerically, and this is a fact, there are more white Americans that are exposed to the adverse social determinants of health that are predictable for suboptimal health outcomes. The rates of disparities are higher amongst black Americans, but the absolute numbers are higher amongst white Americans. That is the real narrative. And because the narrative has been racialized, because America thinks this is a black problem and a brown problem, and because this problem has been contextualized in the sense of moral and social obligation, broader America has failed to embrace this to be a problem. There's a clear disparity in maternal mortalities in white American women. You saw the numbers compared to the other 34 OECD countries. White Americans, even those that have the best outcomes in America, have worse outcomes compared to other wealthy countries in the world. So we have a downstream racial disparity context and a known downstream white American racial context. We have a more macroeconomic context that tells us that the health system is the problem. The design of the health system is the problem. Black Americans have always been the stress test. When the system fails, we get the hardest brunt. We're just the first to feel it. And that masks the underlying problem that affects us all. There's been mention about universal coverage and Medicare for all. I want to say that we have to congratulate the NAACP for advocating for universal health coverage for almost 2 decades, as Reverend Max said. And I stand with that position. In my opinion, it doesn't matter much if we have a single payer system or we have 2 to 3 or 4 payer systems, for as long as everybody is covered. In the US military, a founding principle and a mantra is that no American is left behind. In health, we should adopt the same mantra, that no American should be left uninsured. Insurance must be the floor, and everybody should be able to stand on that floor. We should never be in a position, but we are, where we spend so much money and we have poor outcomes to show for it. It befuddled me for decades until I finally realized that it is not important for America to provide best outcomes for its people, and that health coverage has developed piece by piece in a piecemeal manner. And with that architecture, about 22 million Americans do not have insurance. Universal health care is not the destination, it is the foundation. And as we continue to have these conversations, we have to understand that this fight will be long. This fight will continue to be difficult. It will require effort from every coalition in this room. You leaders, you advocates, we must continue this journey. It is the right fight, and the NAACP and Health Justice are the right leaders to lead it. I want to close by speaking briefly about generational health. Every generation of African Americans has kept the naming of these flames that are burning at us alive. They've done so through generations when others tried to ignore and to forget. So the naming, whether we call it racism in medicine, whether we call it racial disparities in medicine, or whether we say elimination of racial and ethnic disparities, the naming may change. The problem is the same. So what we need to do now is we need to move to ownership. If the system isn't going to protect us to preserve health, we need to know what we can do to protect ourselves. we need to have health literacy. We need to know the knowledge of the health industry. We need to learn how to better navigate relationships. We need to understand the importance of screenings and prevention. Not because the health system deserves a pass, because it does not. It's because our children and our grandchildren deserve a better inheritance. Generational health is a new context, and it speaks, like generational wealth, to how do families and communities preserve wealth today and compound wealth for the next generation tomorrow. Generational health is similar. How do we compound, in a good way, health for the next generation? Because if we compound bad health to the next generation, then we shall have an exponential growth of health disparities. Our grandmothers passed down habits to us. Our mothers passed down habits to us. We need to pass down healthy habits. As a cardiologist, I've often heard, I have a family history of heart disease. But I can tell you that most heart disease is not inherited, and most people who had heart disease did not have a family history. What they did have was a history of bad habits, of lack of exercise, of bad diets, of stress that was ignored, appointments that were missed. And we need to know that what we do behaviorally, like I've just described, biologically, as well as economically, can become entrenched as family culture and can compound to the next generation. Generational health should not be a slogan. And the American health system, even though it gave us an inheritance of poor health, we need to break the cycle. We're not waiting for permission to be well. We're not waiting for the system to decide whether we matter. We're not accepting the next incremental patch that does not transform the fundamental architecture. We need to demand the architecture we were never given. We need to use every tool we have through generational health to close the gaps that our ancestors could not close. We have to hand our grandchildren a different inheritance than the one we received. Thank you very much.